Y'all still there?
Yes, so we're going to begin. Good afternoon. Welcome, everyone. Welcome to the Medical Home webinar series. This is the second webinar in the series of 6. This webinar will be presented by Mitzi and Nicole Pratt. Before we begin, a few announcements. This webinar series is supported by the Health Resources and Services Administration, HRSA, of the U.S. Department of Health and Human Services under Genetic Services Project Grant to Health Research Inc., NIMAC. This activity has been approved for AMA PRA Category 1 credits. There is reciprocity credit for allied health professionals, nurses, physician assistants, and nurse practitioners. The required CME accreditation is included in the slides and handouts. Instructions on how to obtain a CME certificate of credit is also included in the attached handout. These handouts can be accessed through the control panel on your screen. This live webinar will take approximately 1 hour and will be recorded. The recording will be available at a later date. As soon as the webinar concludes, you will be asked to complete an evaluation survey. Please take a few minutes to provide your feedback. Your input will help us in planning future activities. Participants claiming CME credit, please use how to obtain CME credit instruction handout to complete the evaluation survey and claim the CME credit. Again, this handout can be accessed through your control panel. There are no conflict of interest disclosure or off-label discussion to announce. At this point, we would like to acknowledge our colleagues for planning this webinar series and helping with the medical home and care coordination efforts. We thank HRSA for their support. We are thankful to all our speakers and participants of this medical home webinar series for their contribution and participation. Should you choose to ask questions or comment, please use the question box in the webinar tool panel to submit your questions and/or comments. We will cover as many questions as time permits, and responses to the remaining questions will be emailed later. On that note, we are pleased to invite Mitzi and Nicole Pratt to present this webinar on behavioral health, integrating mental health in medical home. We'll begin with Mitzi with a brief introduction. Thank you, speakers, for joining us today.
Good morning. Welcome again to Behavioral Health, Integrating Mental Health in the Medical Home. My name is Mitzi Glass, and I am Lead Social Worker for Outpatient Behavioral Health at Children's Hospital of the King's Daughters in Norfolk, Virginia. CHKD is Virginia's only pediatric comprehensive freestanding hospital. We have 206 beds and serve children and adolescents ages birth through 21 years old. The objectives today for myself and Ms. Pratt are that our learners will be able to define the concept of integration and behavioral health. We will discuss the importance and relevance of integration, especially as it relates to behavioral health. In addition, learners will be able to hear examples of practice strategies from a pediatric regional hospital, CHKD, to integrate behavioral health into the medical home. Thank you again for joining us. So, introduction. What do we know? What has research taught us? Research has taught us that children, adolescents, and adults with mental illness as well as developmental delays are more prone to chronic illness. Those chronic illnesses include diabetes, asthma, kidney disease. In addition, we know that children who have toxic stress and toxic environmental exposures are at increased risk to develop a mental and developmental illness. So examples of environmental exposures include being born into poverty, malnutrition, limited social support, exposure to drugs and alcohol abuse, and a chaotic family life. In addition, we don't want to forget exposures such as lead, environmental waste. We also know that persons with mental illness have limited resources and limited knowledge about their disease. Therefore, they are more frequently seen in local emergency rooms and have more frequent hospitalizations. Persons usually manage their disease in a crisis as opposed to a higher level of continuity of care. So historically, medical care and mental health care have been provided in separate systems. So persons usually have gone somewhere to have their medical needs met, such as a physician's office, a clinic, or a hospital. However, they go someplace different to have their mental health needs met. This has not been cost effective, nor has it addressed the whole needs of the whole person, in a well-coordinated manner and with collaboration. This slide tells us about the current state of mental disorders in children. We know that more children die from suicide combined than cancer, cardiovascular disease, AIDS, birth defects, stroke, pneumonia, influenza, and chronic lung disease. So the problem, again, and this slide reminds us of the problem associated with mental health and with physical illness. So again, we know that persons with mental illness, they die earlier than the general population and have more co-occurring health conditions. We know that 68% of adults with mental illness have one or more chronic physical conditions, and we talked about some of those physical conditions, such as diabetes and kidney disease. 1 in 5, more than actually 1 in 5 adults with mental illness will have a co-occurring substance abuse disorder. So the problem is significant. So of course we need a solution. And that's why we're here today, to talk about the solution, which is integrated care. So this slide really demonstrates and illustrates conceptually what integrated care would look like. Again, it's being able to coordinate care of the person's physical health as well as mental health and substance abuse. Integrated care, we know, produces better outcomes, is certainly more cost-effective, and can really help address the complex healthcare issues of those that we serve. So what is integration? So Dr. Blunt provided this definition of integration, and he's the director for the Center for Integrated Primary Care. Integrated primary care combines, and I highlighted the word combines because it means being able to work together collaboratively, to be able to put the medical and behavioral health services to more fully address the spectrum of problems. Remember, we talked about that our patients and our families have many problems that are addressed and that need to be addressed and are brought to their primary medical care providers. I think that the days of persons going to their primary care providers and just talking about their physical symptoms are gone. I think that primary care providers now are looking at a spectrum of issues and challenges that our patients have. Behavioral health is the promotion of mental health, resilience, and well-being. And I love this definition because it reminds me that behavioral health is not just mental health. It's so much more. Behavioral health believes that persons can bounce back, that's resilience, that persons can have more optimal lives, that's well-being, and that those of us who are willing to look at this paradigm differently are willing to support families and their communities along the journey so that persons can have more optimal health. Moreover, behavioral health incorporates an ecological perspective. So we're not just looking at the individual at the micro level. We clearly understand that behavioral health also factors in the family, which is at the meso level, the community, and the larger society, which is the macro level. So integration in the medical home, it just makes sense. We've talked about that persons are often in their primary care providers, and so they are sharing with their primary care providers the myriad of issues that they have that impact their physical health. So often you're seeing persons and understand that those physical and behavioral health challenges, they occur simultaneously. So medical home providers can identify the existence of the behavioral health challenges. It makes sense because medical homes are positioned to provide more care coordination that should include behavioral health across the lifespan. Across the lifespan means that they can start at birth and really see persons up until adulthood and address those issues. We know that persons have a trusting relationship with their medical home providers. If you've gone to your medical home provider since birth for families and for children, you get to know them, they get to know you, you develop that trusting relationship, and you don't mind sharing information with them. And of course, when you can address mental health issues and behavioral health issues with your primary care provider, it takes away the stigma of being able to obtain behavioral health services. Persons are more inclined to obtain and be open to obtaining medical health services if it's done through their medical home and with their primary care provider. This slide talks a little bit about the 6 levels of collaboration and integration. Earlier, I forgot to mention that if you are interested or thinking about integration, it should really be conducive and be almost custom designed for your particular institution and your particular setting. So there are different levels of collaboration and different levels of integration. So there's some that are co-located, there are some where persons share with their primary care provider in their medical home, but then they may go outside of that system to obtain behavioral health in another setting. So I just wanted to illustrate a little bit from this slide that there are different levels and that there are many models and many approaches. So I want to move now to talking about some practice strategies and some things that we have done at Children's Hospital in our integrated program. I would like to highlight general academic pediatrics. General academic pediatrics is a practice that is located at the main campus of Children's Hospital of the King's Daughters. We have right now 17 practices, medical homes that are associated with Children's Hospital of the King's Daughters. General academic pediatrics, or GAP as we affectionately call it, serves over 10,000 patients ages birth through 21 years old. Our physicians see about 1,000 patients per month in general academic peds. So that's a lot of patients that we're providing a medical home for. The staff includes 8 physician providers. There also are medical residents because we are on an academic campus. We also have nurses. Our behavioral staff is by 1 licensed clinical social worker. We have 1 medical social worker, and currently we have 1 Master of Social Work intern, although there are times when there is more than 1 intern. Behavioral health is co-located. and it's number 4 on the behavioral health continuum that we talked about earlier. So now I would like to talk about some of the practice strategies that we have employed in our in GAP to meet the needs of our patients and our families. So one of the most important practice strategies that we do is that our patients and families are screened. Our patients, I'm sorry, are screened, and they're screened by our physician. We give them a tool called the moods and feelings. Now, your institution may not think that it's appropriate to use moods and feelings for your families as a screening tool. However, I would highly recommend that your institution or your setting or your practice really identify what would be a good screening tool to identify behavioral health / mental health issues. We use the moods and feelings. All of our practices use the moods and feelings because it screens for depression in our young people. It's done for those who are ages 8 to 18, and scores of 13 or higher are referred for a mental health assessment right during their appointment. So that's the beauty of integration, again, is being able to have someone right there on site to be able to identify and to be able to address the needs. Sometimes people will say, so if I get the scores and the scores are positive for depression and anxiety, what do I do with that? In an integrated model, you have a way to make sure that those needs are met. So again, scores of 13 or higher are referred for a mental health assessment right during their appointment, and our LCSW is able to do that mental health assessment. Patients can be referred for ongoing counseling in behavioral health at CHKD. So at CHKD, our integration model is not just in GAP, but it's also within the hospital. I'm part of the behavioral health staff. So again, with an integrated model, you can address the acute need and assess, but you can also have the potential to really think about what happens after we do the assessment. So that would be something to think about for families and for providers who are creating an integrated model, what to do with these young people after you identify that they do have some mental health issues. The other piece, remember we talked about behavioral health is not just mental health. It's a myriad of issues that our families present to us with. So we are able, in our model, to be able to identify issues such as housing, transportation, parenting, trauma, school issues. They can all be addressed and identified by the physician as well as the behavioral health staff right during their appointment. And then we have the ability to make a decision about what to do, how we can provide this family with the services that they need beyond their appointment with their physician. The other practice strategy that I thought was important is all documentation occurs in the medical record. We document in an electronic medical record. We're still tweaking it. However, we are able to communicate, the behavioral health staff is able to communicate with the physician about what's going on with that patient, what the follow-up is, if that patient returns back to the medical home, what has already occurred, what needs to be followed up, and all of that can occur in the medical record. If you're in a setting that medical record, you're not able to use an electronic communication system, being able to just talk to the physicians either by telephone or by face-to-face is so helpful. That's what makes the coordination and the collaboration occur and between the provider and between the staff. Okay, let's see here. ask my co-presenters to talk about transition, and then I guess we have a slide that identifies some resources for providers, and I thank you all for listening today.
So good afternoon. My name is Nicole Pratt, and I am a mom of 2 children with special needs, and I'll be highlighting specifically my daughter, who's 21, who has a mental health diagnosis, and my son, who has other special health care needs. I'm going to go into a little bit further about what I do in a second, but I just wanted to highlight the behavioral health transition because that's what I'm going to be focusing on quite a bit through my part of the presentation about the coordination of services. How do we identify, the supports to transition, the need for an adult medical home and a young adult education to identify advocates in behavioral health. You can go to the next slide.
Thanks, Nicole. Okay.
Nicole, you can talk about transition?
I did. You want to talk about the resources?
Yes, I do. Okay, I'm sorry. Okay, so these are some resources that I thought would be relevant and that would be very helpful for families and for providers. A quick start guide to behavioral health integration can be accessed through the SAMHSA website, Center of Integrated Health Solutions, and we put the link there to be able to access that. Integrating mental health and pediatric primary care is by the National Alliance of Mental Health, and that again would be an excellent guide to help persons who are interested in developing an integrated model into the medical home. Bridging the divide between child psychiatry and primary care, the use of telephone consultation within a population, and there again we put the web address. And then finally, the National Center for Medical Home Implementation talks about the integration of behavioral health and primary care. And we did put the link for that particular resource also. Okay, Ms. Pratt?
Yes, you finished? Okay. You can go ahead now. So again, my name is Nicole Pratt, and I work for the Statewide Parent Advocacy Network for New Jersey. I am a parent professional development trainer, and I also coordinate the Office for the Prevention of Developmental Disabilities project that supports women in the community around healthcare messaging and also professionals. The Statewide Parent Advocacy Network is a parent training information center for the state of New Jersey, other known as PTI, because there is a PTI in every state. It's federally funded and state funded. We provide a wide range of supports and services for families and professionals. We provide a wide range of educational trainings and projects, and also healthcare related topics for parents and professionals. Next slide. This slide talks, you get a look at my family. So this is my daughter, Alexis, and my son, Jordan. As I stated earlier, Alexis was diagnosed with a mental health diagnosis when she was in high school, when she was about 15 years old, and she is now 21. My son, Jordan, has a diagnosis of a developmental disability of cerebral palsy and cognitive developmental delay. Next slide. As I stated earlier, my daughter was diagnosed with a mental illness in high school, and how this happened was I was married, and I was in a domestic violent marriage, which my daughter saw much of what went on, even though I tried to shield her from that. And this was when she was very young, around 6 years old. When I got out of that situation, I did have her in counseling in school just to maintain her But as we know, studies show that children who've been exposed to any type of trauma, typically around the time they get into high school age, which she was, can experience a mental health crisis. And that's what happened. I was actually working in what's called the system of care in New Jersey, which provided behavioral health services, and I'll talk a little bit more about that in a little bit. Therefore, I was able to access those supports and services for her on her road to recovery. Next slide. So with that, with my daughter having been in crisis and be able to maintain and get her the in-home behavioral health services, I decided I wanted, as a mom and working in the field, I wanted also to learn more for my own benefit and for other individuals' benefit, to learn more about what is behavior, how it affects others, and looking at the whole psychology of it. So I decided to go back to school as a single mom with 2 children with special needs. I got my bachelor's degree in psychology in 2011, and I did this while supporting my children, making sure they're getting their services, and successfully graduated with my degree in psychology. And my daughter, during that time, also with getting the in-home services, successfully graduated from high school. Next slide, Kanal. And also during this time, I also knew my daughter needed psychiatric services and supports. So she also, in addition to receiving in-home behavioral health services, she also received counseling services through a psychiatrist, which I had to pay out of my pocket. Her insurance did not cover the services. So I decided to take on that responsibility to give her the utmost care as possible for her to have medication management and some counseling services with the psychiatrist. Next slide. So when we look at behavioral health and integrating mental health into the medical home, it's for me, and I also put this message out to other families, that it's important that your doctors, school, medical home, everybody is all about family support. And how do we make sure that everybody is talking to one another? Because everybody has diverse backgrounds and certain needs. And so what my needs are could be different from another family's needs are. But it goes back to ensuring that the medical doctor, the school, or any other services that a families have, that they all are on the same page and that we allow them to talk to one another, because that is something that helped me greatly to ensure that my daughter was supported appropriately. And I feel that attributed to her being able to get the appropriate services and not be able to stay in crisis such a long time. Next slide. And thank you. In addition to this, we want to look at optimum health and health resiliency. With the medical home, the importance of integrating, again, with the success of my daughter, to ensure that her journey through being able to go to high school, and in high school she also had supportive services as well. That's part of the medical home model. And so she had counseling in school as well as she had an IEP. She had counseling at home. She had the psychiatrist. She had me, and I had other family individuals around me, not direct blood-related family, but what I consider my family is other individuals that were experiencing similar things and being a big support to myself and my children. And the other thing I have of both my children, from mute. I have this quick for both children because I stated earlier, my son has developed, although my daughter has the mental health diagnosis, my son has a developmental disability with cognitive developmental delay. And he is 15, and he has a series of developmental issues as well as some medical issues. I'm very well aware and cognizant of that it's possible that he could go into depression. He may need mental health services down the road. So that's always something that stays in my mind. But again, the same thing as my daughter has a medical home model, my son also has a medical home model. So for children who are dealing with a sort of array of health-related services, there needs to be a medical model between school, home, and the doctors talking to one another. My son happens to have therapy at school, the PT, OT, speech. So all those individuals, I talk to them. I allow them to talk to his outside doctors when necessary. Same thing that I do for my daughter. Although my daughter is an adult, she does allow me to talk to any medical professionals that she is dealing with. And in the college that she attends, there's actually a clinician on staff. She hasn't needed to use them. My daughter has been stable for 5 years now. Been crisis-free, but she has learned the tools that she needs to be able to self-sustain herself, and I support her with that. Next slide. So this is a quote from my daughter about how she feels. I feel that all supports that she received in high school and along with myself, her mother, obtained helps her to be stable. It has also helped her to be better at telling her stories to parents and students. And with that being said, over the past, I would say the last 2 years, Alexis has been able to share her story. She has done some health messaging videos through work around mental health illness. She has also presented to Robert Wood Johnson medical students and sharing her story about the clinicians that has helped her through the journey and how they can be, when they become doctors, how they can be most helpful to families. And one of the things I told them is to listen to the family. The family will give you a lot of information, even if they're not always saying it, but listening is key. I know for me, being listened to and my daughter being listened to was very paramount. My daughter also involves herself in recreational activities at the Boys and Girls Club, and she's also been doing, both my children actually have been at the Boys and Girls Club after school summer programs, and both of them have been involved in Special Olympics. My daughter does track, and my son does basketball competitively. And so just making sure that those supports and services that are there. And also for myself, having the information that helped my daughter really made a big difference in Alexis not being hospitalized. I only had a trip to the psych ER once, and that was enough for me. At that day that she went, she was in crisis, but I worked with the medical professionals at the hospital and at school to ensure that she received the in-home behavioral health services that she had while in high school for about 2 years. And when those services had begun to finish, they come to you and let you know that the services are ending, and the next step is to get the community services. And being the mom that I am, I always research information because I want the best optimal services for my daughter. And this is something that I also express to other parents when I'm in the community talking to families, that you have to look at all options and what is best for you and your child. And what I felt that was best for my daughter was I didn't feel where I was living in a section in New Jersey didn't have the optimal services I felt for my daughter. And that is, having gone back to school, and also I had also worked part-time doing in-home behavioral work. So I was gaining a lot of knowledge that way. And with that, and talking to her therapists and clinicians, I gained a lot of knowledge about how to support my daughter myself. So I've been managing my daughter's mental health for the past 5 years, and successfully has been doing that and to keep her stable. I don't suggest that everybody do that. It's just something that I felt, along with my daughter, having conversations with her, that was best for her, and I've been successful with doing that. Next slide. Other support services in New Jersey, we have the Children's Mental Health Behavioral Health Services, as I mentioned earlier, the New Jersey system of care. Each state has their own child behavioral health system, so you definitely need to access what your state does as far as in-home services or community services. Obviously, everybody has private counseling. Community supports, as I said, the educational system, connecting those pieces in the education system, because if a child is, their health care is paramount. If they're not doing well health-wise, obviously their education will suffer. So we want to make sure that if a child has an IEP, that we make sure that those services are there. If a child has a 504 plan, that if it's needed for counseling, that it's there, or any other type of related supported services, that families have the ability to access those services and making those connections with a counselor or a clinician that is in school. Many schools, I know in New Jersey, are now contract with behavioralists, because there's a higher level of children who have a need for that. And with transition to adult life, as I said with my daughter, she is now 21, and I said this journey started with her when she was 15. So the social emotional pieces, making sure she is now much better socially, emotionally. For a long time, my daughter had trouble socially because her social development was put on hold because of the mental health crisis. And since we moved to a different part of the state, she is now making friends, she's going out, she's, really those linkages that is emotionally helping her to stay stable and developing continued life skills to be able to, at some point, be able to live more independently, because she does live at home with me. But, I also give her a sense of independence and things that she needs to do. And ultimately, self-advocacy. Self-advocacy starts from really very early. But for my daughter, because many of those things kind of were on hold for a short period of time, she now advocates. She even told me something last week that one of her professors in college, used the word handicapped. And my daughter came home and told me that, and I gave her verbiage about what to do to change that language. And she actually did. She advocated for him to change his language. And I said, the word is, use different language, not handicapped or a person with a disabilities. And he was actually open to it. So again, it's advocating even when she's in school to ensure that her professors are using the right language. So that just shows that everything that I've done and everything that everybody else has done has really given her more positive skill sets. And she also works as a mentor in the college with a disability program, supporting individuals with developmental disabilities and individuals with mental health disorders. So she gives back now everything that she's learned about the supports that she had, and now she pays that forward by providing supports to other individuals. Next slide. So we want to look at family and professional partnerships. So in recognizing that negotiation is essential, again, when the case manager came to me about my daughter needing the community services, that was, negotiable. And I told her, I said, I'm going to research it. Our clinicians or doctors always happy about what a parent decides to do with their child. Not all the time, but if the parent gives their reasoning why and they can still support them, then we need to do that. And the respect. Parents want to be treated with respect. We want to be listened to. We want to trust that the clinicians and doctors on the other side are ensuring that they are an integral part of the collaboration piece and relationship that brings families together, to trust doctors and to trust clinicians, because that's what we want. If the trust is not there, it's really hard. And when we look at trust, we also look at cultural values. We look at traditions, and we have to understand what families' cultures are. Not all families will go take their child to a psychiatrist or take a child to get mental health supports and services. That can be a challenge, and I've seen that challenge with some families. But again, it's cultural, and then getting possibly someone of that culture who worked in that field to talk to that parent about what the importance is of getting that child their supports and services. So we want to make sure that we get all those things. In addition to the medical home, that we want to make sure that the coordinated care is there, the preventative services, the urgent care, making sure we know the linkages, referrals if it's necessary through the insurance, if there's any prior authorizations that needed, because many insurances may need that, and also helping families with appeals or fair hearings. It's important that sometimes when a service gets denied, that parents know their rights. Just like in education, there's a set of rights and laws, and there's also rights and laws around how do we appeal something that was denied by the insurance company. Parents really need to it's hard for parents to have an understanding of whether it's a state Medicaid system or private insurance. I always tell parents, ask a lot of questions of your medical provider and your medical insurance provider. There are case managers, and I feel that insurance companies really have stepped up and gotten better with providing case management services for families, and that's why they're there to be able to answer questions for families. Next slide. The next slide is resources for families. These are some information that you can share with families. The Mental Health Primary Care Family Guide, which is on the SAMHSA website. National Center for Family and Professional Partnership. Family Voices. SPAN is a Family Voices chapter for New Jersey. We also have the National Federation of Families. It's a national family-run organization. That link is 120 chapters around the state, and New Jersey is a chapter of it. We also have Parent to Parent USA, which houses parent-to-parent programs across the country, providing emotional and informational support to families. And SPAN is also a chapter of Parent to Parent. And as I said earlier, we are also a chapter of Family Voices that provides mental behavioral health supports to families and children around healthcare. Next slide. And this is our contact information. This is Mitzi's contact email and phone number, and this is my contact email and phone number for any further questions you may have.
Thank you, Nicole and Mitzi, for this presentation. Mitzi, I was hoping to know if you would like to add to the resources for providers.
Yes, yes. Can we go back to this slide? I guess it would be slide 26. We highlighted the first one, but there was also another slide that providers may be interested in called Medical Homes and Integration of Mental Health.
Sure, it's on the screen.
Okay, and also Patient-Centered Primary Care Collaborative. And you see the website for that. Joint Principles, Integrating Behavioral Health into the Patient-Centered Medical Home. And again, finally, SAMHSA, which has the standard framework for levels of integrated healthcare. I think for providers who are interested in the knowledge and the tools to develop an integrated model, these are excellent, excellent resources. And of course, you can always contact me and the providers that I work with for information also. So I just wanted to highlight that slide.
Okay, thank you, Mitzi. And for all the attendees, the table that was shared in one of the slides, it is included as an handout for you to download and access. So at this point, we will take some questions from our participants. So the first one is, we hear from families that their children hold it together in school and fall apart at home. As such, schools sometimes don't see that they have a role to play in the services and supports for this type of students. Do the speakers have any thoughts on this particular comment? So Nicole, would you like to?
Yeah, so let me just reiterate what you said. So the question is about how do we ensure that schools are recognizing and ensuring and working with the families to get the right support and services even when the child's in school and needs the support?
That's correct.
Okay. Well, I can only talk from what I did and what I know should happen. One, parents need to connect and know who are those individuals in the school, such as the guidance counselor, clinicians that are in the school. If a child has an IEP, they should be talking to the case manager. individual education plan. If a child has a 504 plan, many times it's for medical purposes and or educational purposes. They should be talking to the sometimes guidance counselor, whoever's in charge of that, talking about those services. The teacher is one of the primary individuals. So we want to make sure that the parents have the information. I know that it's challenging in many school districts, not just here in New Jersey, but in many states, about them recognizing that they need to support the parent, support the child. It's the parent's role to really enforce that in them, to get a meeting in there and say, my child is getting these XYZ services in the community, but they really need to talk, to have a meeting and talk to someone in the school about what kind of supports the school has, because each school has different types of supports, and what kind of supports they have to get. And the other piece of that is also the PTI, the Parent Training Information Center in their state. To find the PTI in your state, you can go to parentcenterhub.org, and you can actually find your PTI in your state. And they can also be ones to help that linkage between the school and the families to get those supports in there. They can provide some general supports. Because maybe the PTI, someone who works at the Parent Training Information Center, may know someone they can talk to or have a good relationship with someone at the school or even at the district level if the parent is challenged in getting their foot in the door to get the school to recognize that my child needs those supports and services. I just happen to be a really big advocate for my children, and I made the school listen to me and listen to my child in a nice way, but really to pull it together.
I'd like to piggyback on what Nicole said, since I totally agree, and I also think that one of our practice strategies, if you will, is to be able to link with the schools and to support parents, because as Nicole said, sometimes parents, they don't necessarily have the information or they don't necessarily know how to advocate at the level that Nicole does, but we can support our parents and families, because you're right, a lot of issues happen at school. So we hear from teachers, we hear from counselors, and parents also who say, my child is great at home, but at school things are not going well. So we're able to affect some change and advocate and link with the schools, because remember, integration is not, it's at many levels. It's the micro, the meso, and the macro levels. So those, linking with schools and churches and other places in the community is very valuable. So I agree, Nicole.
And the other piece of that is linking parents with other parents who are dealing with it. I always say for that child to find a safe person in that school they can talk to. Many times it's the teacher. For my daughter, it was the teacher. She told the teacher that she was in crisis. But again, the parent needs to know who are those individuals and connecting parents to other parents. So again, through the PTI, they can also connect parents to other parents to, who've had those experiences, because one person may know about someone they can talk to. That's the linkage that we need to make. So it's all about that whole family linkage.
Okay. There is a supplementary to that original question or comment. The question is, can you share some of the specifics on how school staff and external providers shared information? For example, electronic medical records, care coordination meetings, or working with a care coordinator.
So I can speak to that. Because, so if I receive, I'll give you a great example. If I receive a referral for a child who appears to have some depression and anxiety, I can see that child, and then I can put a note, if you will, in the electronic medical record that the physician has access to. So that's I think that answers the question in terms of how we can communicate through the medical record. But we can communicate, so I can see a patient and write a note into the record that the physician has access to.
And the other piece of that, because in schools, you definitely have to get the releases signed. That's one thing I made sure of. I said to my daughter's clinician at the school, all right, I want you to speak to her in home clinician. So I made sure all those releases were signed, and that the doctor always got copies of everything and knew everything that my daughter was, both her doctors, at the time her pediatrician and the psychiatrist, that everybody had the same information, that everybody was on the same page. So it does take some work on the parents' part, in addition to, you know, the clinicians in the medical home, to ensure that these pieces are being pulled together.
Great. Mitzi, I'm recalling our discussion earlier about integration of behavioral health services in specific cases related to genetic conditions. Would you like to share some thoughts on, you know, how behavioral health services are provided at your institution with regard to genetic conditions?
Yes, absolutely. So we have, I think right now we have 2 providers, LCSWs, who are in our developmental clinic. So those providers do assessments and ongoing therapy with children who are on the spectrum, as well as may have other developmental challenges. So we're able to do that right here. In terms of just, you know, genetic conditions. So I think that that's a great question. It's also very, very, very helpful for parents to have someone who's connected with that specialist who understands those developmental issues, to be able to address those right here in this setting. So developmental is what comes to my mind, especially because a lot of those children are born with developmental challenges. If children have other genetic challenges and the physician can identify those, he can also access behavioral health services within our outpatient behavioral health department. And if we can't provide the service, you know, we can do an assessment, we can get them to where they need to be. It may not be in our system, but it may have to be in the community. But again, it's a collaboration. It's being able to identify the need and then being able to meet the need for that parent and that child.
And I just want to add on to that. Sometimes you have to go outside the community sometimes to get specific services. For example, although I live in New Jersey, for my son who needs, for me, optimum orthopedic care, he's been going to Shriners, under Shriners Care in Philadelphia, for all his orthopedic care and services. At the same time, they communicate with his pediatrician. They also, I get releases so that his therapists in school know what they're doing. So again, all these things have to be connected together so he gets optimum care, and same thing with my daughter, both optimum care.
The other thing, Kunal, that I wanted to mention as part of our team, and Nicole kind of alluded to this also, we also have psychiatry, psychology as part of our behavioral health team to help navigate the myriad of issues. So we have licensed clinical social workers, licensed professional counselors, but we also have psychologists and psychiatry who's able to help us with those unique issues that our patients have.
That's great. I'm tying into our first webinar that we had on practice team huddles. I'm inclined to ask whether there is any team huddle or a group meeting between the specialist psychologist in terms of planning or offering behavioral health services to with genetic conditions.
Yes. So my team meets every morning for huddle. So the behavioral health staff, we meet every morning for huddle, and we talk about the patients that we're seeing. We talk about the unique issues. We use it as a time to educate each other, to support each other, to catch up on any outstanding issues that are going on in the hospital. So we huddle every day. In terms of just being able for education, Also, we have supervision every week with our behavioral health staff, where our psychologist meets with us as a time to educate and to be able to process what's going on with some of our patients. And then we meet once a month with our psychiatry, who does supervision and education with us. So, but the huddle piece, that happens every day in our department.
Great. Nicole, any something similar for parents meet or families meet with regard to advocacy efforts?
All right. So what I'm thinking is that, again, you know, the connection between school. If a child has a case manager, the parent needs to communicate with that case manager. Especially when things change, because that's, if a child has an individual education plan, that's the kind of the first course of action. Sometimes the teacher will say something to the parent, but you know, getting that meeting with the case manager, if there are things going on, if it's the guidance counselor or the clinical counselor. So a parent needs to have all that information, access to all that information about who they can speak to. So the parent is the one that would, you know, implement any meetings outside of the normal meetings that they may have to discuss any issues that a child may need. And the parent can call that meeting really at any given time when necessary. And the nurse also, especially if there's medication that is being taken, or even if the medication is not being taken directly at school but at home, the nurse is part of this information and communication, because the nurse needs to know the side effects of the medication, what it's going to do to the child in school. So we want to make sure that the nurse is part of this information as well. That's another part of the medical home and pulling all those individuals together, that the nurse has all those medical records. And I know it is very scary sometimes for parents to share, especially around mental health, to share information with the nurse, but I always inform parents that it's necessary, because your child's crisis is not going to be subject just to a weekend. It can happen at any given time. As I stated earlier, my daughter's happened while she was at school. And so that communication between all these individuals is important.
And I would recommend on the provider side that providers huddle, you know, whatever would be comparable for your particular institution, for the medical providers to huddle and to include behavioral health as part of the huddle. So to create that as part of your model, because it's another mechanism for communication and collaboration.
And also making sure that the parents have the utmost, anytime a parent goes to the doctor and the doctor is making notes, the parents need to request that, or you should be giving the parents the summary of notes to the parents, so they can bring that information to the school every time a child is seeing a doctor for any specialty type of thing. I do that all the time. I did that a lot when my daughter was seeing a psychiatrist. I would get a copy of the notes, bring it to the school, give it to the in-home therapist. I do the same thing with my son, get the notes from Shriners, bring it to the school, especially to his physical therapist. So again, there's that whole, you know, piece where we're coordinating the information.
Excellent. We have time for one quick question, and the question is, Mitzi, does your practice use a shared plan of care to communicate internally with those specialists and doctors involved in treating the patient to ensure integration and consistency of care?
Yes. So what that, and I hope I'm answering the question. I hope this is what you're looking for. So what that would look like, for instance, is if I say, for instance, talking about a specialist. So let's just say it's sleep. GI. So I see a lot of patients from GI. So the physician would inform me of what, and I can do this again through the electronic medical record. They would inform me of what is going on medically with that patient and what they identify may be some of the behavioral health concerns, and then I would be able to communicate with that physician so that we can come up with a plan of care that we can agree on that's going to help the patient. So we're looking at the behavioral health issues the mental health issues, but also the physical issues and how we can work together. So yes, we do have to share. I mean, I don't think you can have integration without really sharing all, without sharing. So I pretty much know medically what's going on with all of my patients, because I have access to that information either through the electronic medical record or face-to-face contact with the physician or the staff that works with that physician. Is that answering your question?
We can summarize his responses and email to all of our attendees, which we intend to do because there are many other questions that have not been addressed. I just wanted to ask Nicole if she had any thoughts on this based on her interactions with the providers or healthcare team members.
As far as with the sharing of the information?
Yes, shared plan of care to communicate internally, or whether you have been part of this discussion with the healthcare teams.
Okay. So there
trying to
are
add a patient perspective.
Right. So there's many different tools that families can use on various different websites. And on our website, the SPAN website, spanadvocacy.org, we have a lot of different resources and tools, medical forms that families can use that can be given to the family to use for their meetings.
Great. On that note, I would like to thank our speakers, Mitzi and Nicole, for a very engaging presentation. As promised, the remaining questions will be addressed and the responses will be emailed to all our attendees. Just want to conclude by going over some housekeeping things. We request all of you to complete a brief evaluation. Your feedback is extremely important to planning future activities. And again, a quick reminder for participants claiming CME activities, please refer to the CME, how to obtain CME credit document in your control panel. And should you have any questions about the webinar series, feel free to contact us at the email address showing on your screen. Or if you have any questions about the CMEs, please contact the Office of Continuing Medical Education at the number given on your screen. On that note, we thank you all for participating in today's webinar. Have a wonderful day.
Thank you.
Thank you.